next session. So we'll have one more paper presentation now. This will be on the long-term efficacy of liposomal amphotericin B for the treatment of visceral leishmaniasis in Bihar. So we have with us Dr. Deepak Kumar. He is stationed in Bihar and he is working for the MSF there, and he has a rich experience in treating these Kala-Azar cases. Please, Dr. Deepak.
So here there is a golden opportunity to share our experience about the five-year program summary and long-term effect of liposomal amphotericin B in the total dose of 20 milligram per kg body weight in divided 4 doses for the treatment of visceral leishmaniasis in Bihar, India. So we'll talk here in an Indian context that this is the visceral leishmaniasis, which is anthroponotic and caused by sandfly. There is India accounts, visceral leishmaniasis accounts 50% of the worldwide visceral leishmaniasis burden. And in Bihar, where we are working Kala-Azar project, it accounts more than 80%. So it mostly it affects poor people in the rural setting. So in 2008, MSF conducted the prevalence study, and point prevalence was 10.4 per 10,000. And there is a data from the national program in 2012 that 16,056 cases were found in 2012, and 27 deaths occurred in Bihar. So let's have a quick look about the recent past treatment of the treatments in India. In the recent past, sodium estivagluconate, which was introduced in 1922, and now these days in its course, it's a poor responding to the treatment. So almost this is the treatment failure. It has started since 1980s, and here you can see the almost 60% treatment failure was there, as per the some documents. And in 2010, WHO recommended to remove the treatment of SAG for the treatment for visceral leishmaniasis of SAG in Bihar. Amphotericin B deoxycholate is also the drug, very good drug, but toxic, and requires long patient stay. Miltefosine treatment for the visceral leishmaniasis treatment is in the plan of national program. In 2005 it was implemented. It is a monotherapy and a 28 days treatment. What is the drawback? That now these days it is the increased evidence of poor response to the this treatment, especially in Nepal and India. Issues might be poor compliance and teratogenic effect. So here, researches outcomes of the ambisome liposomal amphotericin B in the different regime as a monotherapy and the combination therapy. So here you can see that the efficacy rate is good of liposomal amphotericin B from 94 to 97%. There is a small description about our project. We are running in Hajipur for last 6 years. When the patients, as such, this is the endemic zone, and patients are coming from the with the clinical suspected case, 2 weeks fever, and spleen is there. We are doing the RK39 rapid test, which is more specific and sensitive. And after diagnosing, in some cases, we are doing the parasitological confirmation as well. In the cases of relapses, and in highly suspicious case of in the case of RK39 negative, we are doing the parasitological confirmation. And after diagnosis of the visceral leishmaniasis, we are treating with a 20 milligram per kg of liposomal amphotericin B in 4 doses. So we are working in such setup that we are having the 4 levels of giving the treatment to the patient. We are following our treatment in 5 rural settings in PSCs. And we are running some treatment camps in some pockets where the more endemic zones. as well as we are working as a secondary center of the visceral leishmaniasis treatment in Hajipur Sadar Hospital, which is located in the Vaishali district. And we are working as well as the tertiary center, RMRI, in Patna. So this is the one of the PSC where we are working. We are providing RK39 and as well the liposomal amphotericin B. So treatment in primary health center. Primary health center covers block population around 200,000, and in collaboration with the state Health Society Bihar, we are providing free kit diagnosis and treatment with the help of the MOH doctors and the paramedical staffs. Key points of this PSC are 1,400 patients were treated. Doctors only responsible for making the diagnosis and treatment in the PSC setup where the MOH doctors are working. And PSC paramedical staff is quite working all together a very strong relationship, and they are doing the drug preparation, follow-up, and if in case of referral, then they are sending to Sadar Hospital. As I told that there is a secondary center for the treatment. Follow-up for the primary cases of Kala-Azar is done at PSC level, concerned PSC level, where it is diagnosed. No financial benefit incentive we are giving to the patient, and we are doing the close monitoring weekly. So here the background characteristic of patient. Here RK39 positive, 99% was there, and 7.5% was RK13 positive, but parasitological confirmation was done. It was chances of less relapse. And as you can see that the male is more, there is infected with the visceral leishmaniasis Kala-Azar, and mean age group below the 15 there is 47%, and mean time is 6 weeks, and mean hemoglobin is 8 gram, and spleen size is mean spleen is 6 centimeter. Sorry. So nutritional status we can see here in the case of the Kala-Azar, 30%, including moderate acute malnutrition as well as the including the severe acute malnutrition. And from such number of people infected with visceral leishmaniasis, that was 8,730. We are talking about data from 2007 to 2012 for 5 years. So here some co-infected diseases like HIV 161, 1.8% was also found, which we'll talk about tomorrow. So we can see here from the graph there is seasonal variation in visceral leishmaniasis. Peak season in March to May, and it is decreasing as the month goes. To the end of the year, there is seasonal variation. There is less cases of visceral leishmaniasis. We can see, so these are the operational outcomes of our treatment of the 5 year with the liposomal amphotericin B, that approximately 8,500, for the immunocompetent patient we are talking, 8,500 patients around treated with the liposomal amphotericin B, as well as at the outpatient basis where we are working as the treatment camp and the PSC level, primary health center, these are the 99%. So same 99% initial cure in immunocompetent as well as the PSC level with the close monitoring with the help of MOH staff, there is a 99%. Treatment effect, we are seeing the treatment effect on the biomedical parameters. That is the regress in the spleen size, hemoglobin, and increasing of weight. We are, after giving the treatment of liposomal amphotericin B, I am talking about the 20 milligram per kg body weight and divided 4 doses. So some patients, there is a data 0.1 discontinued due to allergic reactions. And here, just I want to, when we started the treatment of liposomal amphotericin B, 20 milligram per kg body weight in 4 divided doses. Earlier, we started in the 4 doses, but in the 10 days interrupted treatment. Now, for last 2 years, approx, we are treating as a daily regime treatment. So there is no significant difference in the initial cure and the tolerance between the daily regime treatment and the for 10 days interrupted treatment. So we Actually, we are doing the follow-up, but last year in March 2012, we actively followed to check the relapse of, to the 20 milligram per kg MB zone, who had treated those patients who were treated for the liposomal with the liposomal amphotericin B. Inclusion criteria was taken for the 18 months, and time period was for those patients who were treated with liposomal amphotericin B from September 2010 to December 2011. And these patients who were belonging to the 8 blocks in Vaishali district, and HIV status was unknown. We picked the 984 patients as per the inclusion criteria for 18 months, and 827 was traced. So we can see effectiveness estimates for the liposomal amphotericin B for the 5 years program for those patients who were who got treatment of liposomal amphotericin B, that the 0.3% relapse in 6 months, and majority of relapses, 3.2, occurred between 6 to 12 months follow-up, and 1.9% relapse between 12 to 15 months. During this active follow-up, which we followed as per the inclusion criteria, like from here. So we put this estimated effectiveness in the Kaplan-Meier program, and there is it appeared like a step pattern. The cumulative risk of relapse in 6 months, 12 months, and 18 months were 0.5%, 2.8%, and 4% respectively. Risk factors, it shows Kaplan-Meier relapse, shows risk factors for relapse. The male sex are more involved, and the p-value was less than 0.00. We thought initially that might be age factor, hemoglobin, and the spleen size and nutritional status will also affect, but in true manner, it showed no significant association. So this is the mean time to relapse, that is 9.6 months, around 9 months, 10 months. So conclusion and recommendation of our 20 milligram per kg body weight, which we are following for the last, this is the 6th year, but the last 5 years I am just giving the data. So conclusion and recommendations from our side, that has a low overall and long-term relapse rate. It is safe, effective, and few severe adverse events, but remains unfeasible, expensive, we agree. May have utility in refractory cases or rescue regimens in the Indian subcontinent.
The central policy and the guidelines are there that SSG has been removed and miltefosine is now first line of treatment, oral drug, which is being done. And most of the districts, because the Kala-Jar elimination strategy is bring down the cases less than 1 per 10,000 population. So out of total 584 blocks of Kala-Jar endemic in entire 52 districts, 383 had already achieved that elimination target, which includes mostly 11 districts of West Bengal. They have done wonderfully well. UP is already finished. Some sporadic cases are coming. And Jharkhand, 2 districts have successfully done. 2 districts there are some problem. That is what I told in LF also, for malaria also. For Kala-Jar, same thing, that because people, health workers cannot go there beyond that area because of different problems in the country. So now the focus is to intensify and improve the treatment compliance 100% to those blocks which are still showing more than 1 case per 10,000 population. That is what the mapping is being done. Second, take the help of these research groups and other collaborators who are doing. There is a National Task Force Technical Advisory Committee headed by the Director General of Health Services, where all these issues are discussed. And then there is a change in the national treatment guidelines is given. So far the results are being discussed if they are submitted. Recently we have given for miltefosine and other amphotericin B. Thank you.
So I think we have to stop here, and Okay, Marlene. Yeah, please.
Oh, sorry. Well, no, I wanted to come back to the important question Dr. Kakar asked to our colleague from Cuba about the compliance and the use of the vector control tool. And because I wanted to ask the same question, what was very interesting in Dr. Pradeep's presentation on the way you assess independently by the medical college involvement in Karnataka, by these compliance surveys. So my own question was, is that a standardized tool? Are these colleges then all implementing the same survey questionnaire, and do they do it in the same way? Because to make the interpretation possible. But I would like to hear from Cuba as well.
There is a very clear protocol that is followed across the country. The Directorate of National Vector-Borne Disease Control Program has made a protocol that has to be followed by each of these medical college groups. So standard questionnaires are used, and a minimum set of people are interviewed, a particular sample size is followed, and analysis is also done systematically. So I think they are comparable, and they give us valuable data. Should we close?
Yeah, I think we should have to stop here. So I thank all the speakers and the audience for their patient hearing. So now I move on to our speaker, to our chair, co-chair, Mr. Dr. Kumar, to say a few words.
We have had a very exciting session. We started with the keynote speakers who told us the basics, the epidemiological principles, the challenges, the way forward, etc. Then we came out with a number of presentations by different researchers who have collected a lot of primary data. We have had policymakers talking to us regarding the fantastic developments that have gone on. So overall, we have had an excellent session, and I am sure the colloquium is greatly benefited by the wisdom of all these people. So I thank the keynote speakers and the presenters to make this session, for having made this session very successful. Thank you very much. So we look forward to announcements from the organizers.
Oh, I've grown taller now. We would like to thank the chair of this session, Dr. Ravi Kumar, for accepting our invitation and effectively managing the time, sir. So please accept a small token of appreciation. Thank you, sir. We thank Professor Roy for co-chairing this session, and we appreciate you for accepting our request, sir. Kindly accept a souvenir as a token of gratitude. Thank you, sir. We thank Professor Jacob John for delivering keynote speech, and we are grateful that you could be with us, sir. Please accept a moment as a token of recognition. Thank you, sir. We'd like to thank Professor Suman Rajal for giving keynote speech. So would you please accept a remembrance as a token of acknowledgement. I'd like to thank all the presenters of this session for their enriching presentation. Thank you. Thanks to all the delegates and the participants who were part of this session, and we hope this session has generated some thoughts and helped the cross-learning. Thank you. There are some few announcements to make. The poster holders are kept outside this hall, on the left side of this hall, to display your posters, and it has your name sticked below the frame. Please put your posters up on the assigned holders. And if you have any problem, you can contact the organizers, and you can recognize them with this red tag. And to leave your comments, we have put whiteboards near the posters and also left the sticky notes. If you want to leave your comments, you can write your comments on the sticky pads or the notes and stick it on the board which we have placed there. And for travel reimbursement, please contact Ms. Gaja, who will be sitting at the registration counter at the entrance of this hotel, and she will be there between 2 p.m. to 5 p.m. And if you have any problem, you can contact the organizers. I know you're all hungry to go for a lunch, so now we will break for a lunch, and which is served outside the hall. And we will start the session 3 on planning and evaluation in disease control at 1:45 p.m. in the same hall. And I request all the presenters to share their presentation with Mr. Diljit, who is sitting on my right side. And I kindly request, even if you have sent your presentation through email, if possible, please give it through the pen drive, if possible. Thank you. And please enjoy your lunch, and we look forward to seeing you here in the next session. Thank you. Thanks, one and all. Sorry, I just forgot one thing. The feedback forms are kept on your tables. If you can if you write your feedback and leave it on the table, we will collect it. Thank you. It's on your tables wherever you are sitting. Thank you very much.